afternoon, February 28th. It's healthcare, and we're turning back to H 266, which is, I'm just referring to as 340B. And I'm going to do some markup on the bill at this point. So if Jen, legislative council would like to join us.
Good afternoon, Jen Kirby from the Office of Legislative Counsel. So if it's helpful, I can put the bill up on the screen and we can kind of go through it and remind you what's in it and see what you might want to modify. So H 266 is an act relating to protections for 340B covered entities and 340B contract pharmacies. And it adds a new subchapter in Title 18 on the 340B drug pricing program. It starts off with a lot of definitions that we looked at the other day. And then section 4682 is prohibits discrimination against 340B entities, and it talks about what a manufacturer or its agent shall not do, shall not deny, restrict, prohibit, or otherwise interfere with, directly or indirectly, the acquisition of a 340B drug by or delivery of drug to a 340B contract pharmacy. And that is prohibited by the federal government. Also not requiring any specific claims, utilization, encounter, purchase, or other data as a condition for allowing a 340B contract pharmacy to acquire or take delivery of a 340B drug, again, unless it is required by the federal government. It prohibits them from interfering with the ability of a 340B contracted pharmacy to dispense drugs to eligible patients of a 340B covered entity. It requires the manufacturer to make available 340B drug pricing to a covered entity or contract pharmacy in the form of a discount at the time of purchase and not a rebate later on. So that's the piece on just kind of the manufacturers and the contract pharmacies and 340B covered entities. And then 4683 is about reimbursement of 340B entities. And these are provisions around what a health insurer, pharmacy benefit manager, or other third-party payer or its agent, prohibitions here on them doing a number of things, many of which are in our existing law, but in the pharmacy benefit manager statute, not in this standalone. So it's actually moving them here and deleting a lot of them or striking out a lot of them in the next section.
So
keep going, discuss.
So this is existing law.
Some of it is, some of it isn't.
What
I think.
what
I can't do that on the fly, so I would have to compare and look.
Okay. Because so there's a section in this bill that strikes out existing law
Yes.
and replaces it with this.
Yes, so this is more extensive. The language in this section is more extensive than what is in the existing law, but I can't tell you. I'm happy to come back
Okay.
when you get back from break and tell you what's different, but I can't do that.
Okay, that's fine. All right, let's continue. Well, so I think for concerns in regards to, so the previous section pertains to what a manufacturer can limit, or it limits what they can limit.
Yes, right, exactly. It limits what they can do with respect to 340B covered entities and contract pharmacies.
Which I think from most of our witnesses, the concern is really around this piece that we're seeing in Vermont right now. So this section, think expands. Let's wait until we get to the part that's struck out.
Okay. So do you want to keep looking at this kind of the payer side, or do you want to go down to the struck out language?
I'm sorry, I'm like thinking on the fly. Let's continue through the bill and then go back to the pieces.
Okay.
And we've looked at it in the whole.
So we're in the reimbursement and the health insurer, PBM or other third-party payer or agent shall not do. They shall not reimburse a 340B covered entity or contract pharmacy for a 340B drug at a rate lower than that paid for the same drug to pharmacies that are not 340B covered entities or contract pharmacies, or provide lower reimbursement for a claim on the basis that the claim is for a 340B drug. They cannot impose terms or conditions on a covered entity or contract pharmacy that differ from those applied to non-340B contract covered entities or contract pharmacies, including, and then there's a list. They cannot impose fees, charges, clawbacks, or other adjustments or assessments, including any additional requirements, restrictions, or burdens on the 340B covered entity or contract pharmacy that results in administrative costs or fees that are not placed on other entities, including affiliate pharmacies of the health insurer, PBM, or third-party payer. Cannot use dispensing fees that are less than those for non-340B covered entities or contract pharmacies. Cannot impose restrictions or requirements regarding participation in standard or preferred pharmacy networks. Cannot impose requirements relating to the frequency or scope of audits of inventory management systems. Cannot impose requirements that a claim for a drug include any identification, billing modifier, attestation, or other indication that the drug is a 340B drug in order to be processed or submitted, unless that is required by the Centers for Medicare and Medicaid Services, CMS, or the Agency of Human Services for administration of the Medicaid program, or any other restrictions, conditions, practices, or policies that are not imposed on 340B entities. They cannot require a 340B covered entity or contract pharmacy to reverse, resubmit, or clarify a claim after initial adjudication, unless those actions are in the normal course of pharmacy business and not related to 340B drug pricing. Cannot discriminate against a 340B covered entity or contract pharmacy in a manner that prevents or interferes with the patient's choice to receive drugs from the covered entity or contract pharmacy, including for administration of the drugs. And for our purposes here, it's considered a discriminatory practice that prevents or interferes with a patient's choice to get their drug from a 340B covered entity or contract pharmacy if the payer places any additional requirements, restrictions, or unnecessary burdens on the covered entity or contract pharmacy that result in administrative costs or fees, including requiring a claim for a drug to include any identification, billing modifier, attestation, or other indication that it is a 340B drug in order to be processed, submitted, or resubmitted, unless the indication is required by CMS or the Agency of Human Services for administration of the Vermont Medicaid program. And they cannot include any other provision in a contract between the payer and the covered entity or contract pharmacy that discriminates against the covered entity or contract pharmacy or interferes with the patient's choice to get their drugs from that entity or pharmacy, including an administration of the drug in person or through direct delivery, mail, or other form of shipment, or creation of a restriction or additional charge on a patient who chooses to get their drugs from that entity or pharmacy. Cannot require or compel the 340B covered entity or contract pharmacy to submit ingredient costs or pricing data about 340B drugs to any payer. And they cannot exclude any 340B covered entity or contract pharmacy from the payer's network on the basis that the covered entity or contract pharmacy dispenses 340B drugs or refuse to contract with the entity or pharmacy for reasons other than those that apply equally to non-340B entities. Then it says Medicaid is unaffected. Nothing in this subchapter shall be deemed to apply to the Medicaid program as a payer. Violations, this allows a 340B covered entity, contract pharmacy, or other person injured by manufacturers, insurers, PBMs, or other payers or agents, violation of this subchapter, to bring an action in Superior Court for injunctive relief, compensatory and punitive damages, costs and reasonable attorney's fees, and other appropriate relief. And a violation occurs each time a prohibited act is committed. So for purposes of the manufacturer provision, a prohibited act is defined as each package of 340B drugs that is subject to a discriminatory action by a manufacturer or its agent. And for the payer piece, a prohibited act is defined as each day that a health insurer, PBM, third-party payer, or agent engages in a discriminatory action toward a single covered entity. And it says there's nothing in here should be construed or applied to conflict with or be less restrictive than federal law or a person regulated by this subchapter. Section 2 strikes out some language in the pharmacy benefit manager statutes in 18 VSA 3631. So in this piece, it's striking out the prohibition on the PBM or other third party reimbursing a 340B covered entity for pharmacy dispensed drugs at a rate lower than that paid for the same drug to pharmacies that are not 340B covered entities, and from assessing any fee, chargeback, or other adjustment on the covered entity on the basis that the covered entity participates in the 340B program. For a patient who is eligible to receive drugs that are subject to a 340B drug pricing agreement, a PBM cannot discriminate against a 340B covered entity in a manner that prevents or interferes with the patient's choice to receive drugs from the covered entity, specifically carves out Medicaid, and prohibits a PBM from requiring a claim for a drug to include a modifier or supplemental transmission, or both, to indicate that the drug is a 340B drug unless the claim is for payment directly or indirectly by Medicaid, or restrict access to a pharmacy network, or adjust reimbursement rates based on the pharmacy's participation in 340B. And it would take effect on passage.
Anyone have any questions for Jim? Topper and then Leslie?
Excuse me, discriminatory action. That, I can't find the definition.
It's, I would say, more of a sort of umbrella term here used. So you can see on the top of page 3, that section is titled Discrimination Against 340B Entities Prohibited. And it's really about treating them differently from non-340B entities. So they can't deny, restrict, prohibit, otherwise interfere with, acquisition of, sort of can't interfere with the operations of covered entity or contract pharmacy operating under the 340B program, require them to do things, those entities to engage in administrative processes that wouldn't apply to a non-340B covered entity. So it's not.
That's the description.
Right. So it's really sort of, it's a descriptive term
Yep.
encompassing all of that treatment that is different for a 340B, that is treating a 340B covered entity or contract pharmacy differently based on the fact that it's participating in the 340B program. Question?
Yeah, Leslie.
I just don't know what a package of 340B drug.
That was language provided to me, so I might look to the sides of the room, see if people know what specifically was intended by package. I just thought when I said it too. So the
It's on
violation is,
page-
yeah,
Page 7, line 20.
yep, violation occurs, or prohibited act is each package of 340B drugs that is subject to a discriminatory action by, I don't have a specific definition. I would have to look at the federal law to see if that is a defined term.
Yeah, it's not in our terms.
No.
No. I'm not sure.
Good question.
But I don't know what it's mad. I mean, I'm trying to, it must have to do with how they get dispensed, so, but whatever, I'm curious.
It's a good question.
Would anyone like to weigh in? I'm sorry, I don't have my glasses down because I'm,
No.
so I can't actually see if anyone's being responsive. Okay. Any other questions for Jen? Go ahead.
I'm not sure if this is the right time, but I'll throw it out. We had talked about 202 yesterday, maybe adding section 3, and I didn't know if you were gonna go there or not.
Yeah. I will tell you, I am gonna go there.
Okay.
So I think that, you know, most of the testimony we heard and, based on sort of a consensus. First of all, I'd love to get rid of 340B altogether, but that's federal thing, so I can't do that, but.
Yeah, you said yes.
That's not on the table. I think that it's been identified that the problem and where possibly we need some guardrails in Vermont has to do with manufacturers and the manufacturer's ability to control things. And for purposes of this bill and through lots of work by stakeholders, I'm interested in removing sections that pertain to other entities rather than just manufacturers. And so I think that that would be removing certain sections of the bill. And mainly, I mean, making some tweaks along with it, but mainly keeping or striking out the section around the reimbursement.
What number is that?
So it would be page 4, top line 1. Because this is existing, well, this is based on the existing law that we have, that we did the work around with PBMs last year and their restrictions or their reimbursements. And leaving out extending it to health insurers or other third-party payers or agents. And so if we struck out this whole section, it would revert back to what's already in existing statute.
Right, if you struck section 2, that
Yeah.
strikes out the language.
Yeah, of course.
So my understanding that you're saying this is already in that.
Some is, some isn't. I don't believe that, I mean, it's not, it's right, it's not an exact duplication, but I'd have to look at it to see if it's the extent to which it's just different phrasing that gets at the same concepts. The PBM, yeah, so I have not done that analysis.
I'm gonna propose that we.
And people involved in the process may have a clearer sense
Yeah.
where it does.
So you're just gonna, you're eliminating in I think line 3, health insurer and other third-party payers.
Well, okay, so this whole section,
Yeah,
and there are some additional things in it,
that's what,
but the page 8 and on to page 9, all that language that's struck, we would remove the strike
yes.
and just keep it. It's sort of doing the same thing. Oh, not, because there are some additional things in here,
Okay,
but it's just keeping it as it is. So for the purposes of this, what we would do is we would strike this section out. Is it this section?
We would delete
Delete.
from the bill, we would delete section number, well, the language on, starting on page 4. Here, I'll put it up on the screen again.
you got it.
So from a structural standpoint, we would delete everything that's in, starting on top of page 4 in what is here, 18 BSA 4683, which is a new section. We would just eliminate that from the bill, and then I would renumber to the extent we need it. 4684 as 4683, and 4685 would become 4684. And I would take out all the references to health insurers and PBMs, which means we also only need to talk about the manufacturer piece here and not the health insurer. I'd also take out definitions like health insurer if they're not used anymore in this chapter. Renumber no conflict with federal law as 4685. Take section 2 out of the bill entirely, and the effective date section would be section 2. We just wouldn't be touching the underlying law, which means we wouldn't be deleting it, and it would stay as existing law. So we're not taking the strike through out and keeping it in the bill, because that's just existing law. If we're not doing anything with the existing law, we don't put it in the bill.
Thoughts from anyone? I think that it still maintains a strong bill, and we're really getting to the purpose of what we're trying to achieve with this. Everyone in general agreement, and then Jen can mark up over whenever, and we'll take a look at it. Great. All right. So we'll
You
go
want
ahead
me
and
to
do
put
that.
up 20 in the section from 202 as well?
Yeah, well, I was going to talk about 202.
Okay.
So we listened to 202 yesterday, which was sort of around that reporting piece. It was, you looked at section 3 and 4. So do you want to, so and is it appropriate? Would it be appropriate? Is it germane? Could we move one or both of those sections, whatever we decide, could we move them into 266?
It seems related. A question of germaneness will be up to the speaker and the clerk. But they certainly seem related in that they're both dealing with 340B drug pricing program.
So let's look at 202 if we can. Alan.
Okay, I'm just wondering, because they're germane, we want to combine them. We do not want to keep them separate on their own merits.
Well,
I think you'd be taking out potentially pieces of 2 different bills. So then you'd be doing strike all amendments on 2 bills. I think if you think the committee is concerned that one won't make it all the way through the process, or that aspects of one of them might tank the rest of it, you might want to keep them separate. If you're sort of looking to move a package of ideas on 340B, it makes sense.
Okay, so we got to figure out if it's proper to combine them or leave them on their own merits in 2 bills. Let's see, let me see what that 202 reads.
Okay. 202 is the.
You've just sold me on this bill, and I don't. You start adding stuff, I might change my vote again. So-
This is recording.
No, you guys, you make it confusing.
All right, section 3 from H202 is reporting on participation in the 340B drug pricing program. And this is the language we looked at yesterday that requires hospitals annually, hospitals participating in 340B, to submit to the Green Mountain Care Board a report detailing their participation in 340B during the previous year. And the board would put that report on its website. And there's a list of different information that the hospitals would be reporting as part of their 340B report. You can go through it if you want, but just to remind you what this is. So if you're looking at 202, it starts on page 4, section 3.
sorry, this is 206.
202.
Okay.
Oh, I'm sorry, I didn't,
No, that's okay.
everybody have it?
We're getting there and.
Okay.
All right, so the things that would need to be included in the report, at least in the bill as introduced, is the aggregated acquisition costs for all prescription drugs that the hospital obtained through 340B. This is mainly all for the previous calendar year, so I'm not going to keep repeating that when we walk through it. The aggregated amount that the hospital received for all prescription drugs it got through the 340B program and dispensed to patients. The aggregated amount that the hospital made to pharmacy, aggregate payment amount that the hospital made to pharmacies that the hospital contracted with as a 340B contract pharmacy. The aggregated payment amount that the hospital made to any other outside vendor for managing, administering, or facilitating any aspect of the hospital's 340B drug program. All other expenses related to administering the 340B program, including staffing, operational, and administrative expenses. The names of all vendors, including split billing vendors. I don't know if you got the answer to your split billing question yesterday when I wasn't here. Split billing vendors, contract pharmacies, and PBMs that the hospital contracted with to provide services associated with its 340B program participation. The number of claims for all prescription drugs the hospital obtained through the 340B program, including the total number of claims and the number of claims reported separately by payer type, including Medicare, private insurance, and uninsured. A description of the ways in which the hospital uses savings from participating in 340B to benefit its community through programs and services funded in whole or in part by savings from the 340B program, including services that support community access to care that the hospital could not continue without these savings. A description of the hospital's internal review and oversight of its participation in the 340B program in compliance with HRSA program rules and guidance, and such additional information as the board may request. That is section 3.
Remind us what section 4.
Section 4 was require a couple of disclosure requirements to consumers. First, within 6 months following the end of the plan year, insurer must provide to each covered individual covered under their plan a report of the total amount the plan actually spent on prescription drugs on that person's behalf during the previous plan year, net of all rebates and discounts. And that would go to the same address where the person gets their explanation of benefits. And also annually by March 1st, each covered entity participating in 340B must notify its patients if one or more of the prescription drugs prescribed for them by a professional affiliated with the covered entity was purchased through the 340B program. And if it's a hospital, it also has to include information on how to access the section 3 report.
Any questions for Jen on what we just read? Yeah, of course.
Probably gonna ask the question. If we did combine that, would we just put in 40, I guess, that section 39406 embedded in there somewhere? That how the.
Yeah, I probably-
Did from one and put it.
Yes, yes.
I don't think we've done that a whole lot. Well, I don't think so.
We've done it some where we've sometimes looked at standalone language that then we've put
Yeah,
into
yeah,
a bill.
Yeah. Thank you.
So, yeah.
Alan, so.
Alan.
Is that like what your mother calls you?
Go ahead.
I just need to know your middle name then.
Robert.
Alan Robert.
DeMar. No. So I think that in general, section 3 of the bill, of this bill, seems to have some really worthy information that we might want, that the Green Mountain Care Board might want. In fact, I was thrilled yesterday when the board, was it yesterday, whatever day we did this, when the board came in and the 2 positions that we had created last biennium, were the two people around prescription drug affordability. And I think that this is really valuable data that they would be able to utilize in, you know, the tasks that we set them up to do. And I know that Alan and several people had problems around section 4. So I'm gonna suggest that we just take section 3 and put that into the bill.
And then still talk about it. Like just put it in,
Yes.
right, and then we'll
And still
continue
discuss.
conversations
And then
about it.
we'll continue conversations around it.
I like that.
Is that good? All right.
All right.
Speaking of conversations around section 3, we received great comments from Green Mountain Care Board. And I realized that, of course, Jen, yeah. They are on our website under 202.
And I can put them up on the screen if you want.
And we can talk about possibly incorporating some of their thoughts into section 3, which now is probably going to become another section number, but for purposes of today.
So I think it's from section 2.
Okay, the old section 3, now the new section 2.
Do you want me to put the board's testimony up on the screen for you to discuss, or you want to look at it on your own devices and keep the bill language up?
Is that today? When did that?
Yesterday.
Why don't we put it up? We can go through it together. That way, if we have it up on the screen, we can sort of be looking at the bill on our screens.
This is Catherine O'Neill.
Yep.
So their first suggestion was that we put some intent into the beginning of the bill or the statement of purpose.
Well, there is no statement of purpose, so you have to just. There's a statement of purpose for the bill as introduced. Bill's already been introduced, so now you're doing a,
Okay, and you can't edit can you edit statement of purpose? Okay. I thought there was something around that.
yeah, bill's already been introduced, so now it's moves on from there. It's just a statement of purpose if the bill's introduced. You could put a purpose section in the beginning of the bill. You could have section 1 be purpose.
So is that what they're suggesting here?
Probably.
There's a purpose section?
I think one question becomes, is that, you know, is this,
Catherine,
I guess there's a few questions. Is this something that you would want to codify? Do you think this is important to put into the statutes in order to understand what comes next? Or is this something you would put into the bill so that somebody reading the bill and then the act would be able to see this? Or is this really just, are these really more talking points that you would use on the floor to explain why you were proposing that the House adopt the bill?
Any codified? Yeah, not codified. Anyone have strong feelings about codifying? Okay, so we will move past.
Yeah, I would generally think these aren't necessary to put in statute.
Okay.
But whether you want to put them into the bill as a, you know, section 1 purpose, or section 2 and then have section 3 stay at section 3, we can do that, or you can use them to explain to people why you wanted to do this.
Yeah, I like that idea because it's always easier to get started on a bill when you understand the global purpose.
If we do that and we create a new section 1 statement of purpose, doesn't that codify it?
No,
Oh,
no, it
okay,
just puts it in the bill. Codify means it goes in the green books. It means it goes into the VSA. We're not putting it
okay,
into the VSA.
okay,
It need to be a statute.
all right. Does anyone have one like that idea? Leslie,
I like that.
anyone else have strong opinions that it should or should not be in
There
there?
you go. I don't know if I got strong opinions, but we're making this very confusing and complicated. And I'm not 100% sold on what the Green Mountain Care Board's authorities are. You know, we're giving them authority. We just talked about modern thing with the Green Mountain Care Board. Now we're talking about this with the Green Mountain Care Board.
Well, this isn't, for the most part, all the Green Mountain Care Board is doing in this
It's-
bill is
yeah.
receiving a report and putting it on their website.
Okay.
However, their staff have given you some suggestions on what you might
Okay.
do with your
They're giving
bill.
us suggestions.
Yes, but so far there's no,
Hmm?
what?
I was just gonna say, those suggestions are from the Green Mountain.
Yes,
Care
they are,
Board.
yes, they are from the staff. They're from, actually from the person who's standing up the prescription drug regulation function of the board that legislature tasked them with last year.
So we're not giving them any authority.
No,
Right.
We're
I
just
know, I
saying,
know.
you need to report this.
Well, in the past, as I remember, the Green Mountain Care Board has asked for this information. Past, and the hospitals have been willing to provide whatever they've asked for. I don't know whether this is necessary.
The whole section or the additional comments that the board
I
has
would just
made?
say the whole section. but-
The whole section. Deb, and then Lori.
I did talk to a board member of a local hospital, and he said they do report this information already.
Lori?
Are we talking about the whole section 3?
Well, that's what I'm trying to,
So I,
Woody just said the whole section 3. So do we want to talk about the whole section 3? Or the board's comments on section 3?
say, I think section 3 should go into 266. Because I do think it's important to have reporting on the 340B program. I think we put it in and then we come back after break and hear additional testimony on what might already be reported and what may not be reported and what we need. But I think to do 340B and not have some reporting in. Like I would. Maybe to not that extent, but something.
So you're suggesting that we put section 3 in and then come back after break and incorporate the board's thoughts
Yes.
if we so choose.
Yes.
Okay.
And and I apologize, were there other people, and because I can look at it over break, is there other testimony that reporting that we've taken?
Other than, I believe the hospitals we took testimony on 202 from,
That's fine, I can find it over- and I'll look at it over break.
okay.
Right, I think the hospitals testified on 266, but not.
All right, and then we could have maybe the hospitals come in and testify on that. Leslie, did you have?
I agree with her, Lord. Chair.
I
agree with that too, because-
Oh, you're right. 2 years of it.
I agree with that because I like this setting a standard that creates, I mean, hypothetically would create some efficiencies in our system because one hospital's reporting it doesn't mean they all are. And I'd like to be able to kind of create that standard in writing that we can expect everyone to have these reports. And since we created those two positions, I think this is kind of a natural next step. So I'd support that and would look forward to exploring it more after break.
I'd like to know how much time and effort, our hospitals would have to track this and report it.
Yeah, that's important.
Then let's have the hospitals back in next week.
How much time and effort, how many, manpower hours would have to do.
Yeah.
This requirement.
So, I'm agreeing with, Lori. Let's put it in, come back after the vacation and talk about it again. and bring the hospitals in there.
Fair enough.
Hi, Leslie?
Yeah, just looking at the testimony from the community health centers and really the impact of the 340B program and loss of revenue. And I think we need to understand that. And this helps us understand what the trend is, that's why I think we should.
Yeah, this is only hospitals reporting though. This is not community health centers
True,
reporting.
but yeah, you're right.
No, that just, if you wanted to change it, that would be.
Yeah, no, I'm not changing it, believe me, but I think that it's applicable.
I agree with Lori as well. I actually feel quite strongly that this piece needs to be in there. To me, it's about transparency. And if anything we've learned in the testimony over 340B, it's that it's a bit of a, I guess, quagmire or difficult to understand. And I think the more information that we gather, and again, I talked about the Green Mountain Care Board working towards affordability and prescription drug pricing. I think that this is incredibly valuable information that they need. I think that it's probably already being done. So I'm not sure the owners, but we will get testimony on that. So when we come back from our break, it's not a vacation, Topper. We call it a vacation.
It'll be vacation for me.
We come back from our town meeting break. We will do that. So I guess right now we'll just incorporate this section into that. Okay?
One thing I do think would be helpful, and hopefully some of the testimony can speak to that, is the terminology around savings that the board said is not accurate terminology, and maybe should be revenue or profits or something. I think it'd be good to get some guidance on from stakeholders on what that term should be.
And you plan, Jen, that we get that after the break?
Yep.
We're discussing.
Being that up there as one of the comments from the board.
We definitely need testimony, not that there are people in the room, but I'd like people to be able to prepare for it, not just on the fly. Comments. Leslie, did you have?
Yeah, I was just referring back to the HC language, I'm talking about the Minnesota Transparency Report, and that is hugely helpful for if people have time in their non-break vacation. Look at it.
On your vacation, as you're sitting under a palm tree.
It might help our conversation.
Nancy, you can send me an executive summary of it.
It's actually, it's right in there. It's
Yeah, I
like
know
2
it is.
pages, yeah.
All right. Anything else we need to address? Yeah. All right, so is everyone good with all of us going on vacation while Jen diligently still is working? I know. And marking this up for us and then giving it back to us on Tuesday when we get back? Are you good with that? Yes. Great.
Thank you.
Woody, did you?
No, I was just thinking about Tuesday.
No.
It's been about 5
Not good for your mental health, Woody.
You want to check it out?
I think we're,
They should be checked out.
still on live, just to, all right, so I think we're done for the week. And done for a month, the first 2 months. And off to break. And however you choose to spend that time.